Namaste and good evening, everyone. A warm welcome to Onco Connect Live, a multi-cancer eSummit Day 2. We are honored to have you join us for this two-day event. With immense pleasure, I would like to invite Program Convener Dr. Sachin Jain. Sir is consultant medical oncologist at Ayush Gynecology Center Clinic and professor at TIMS Medical College. It's over to you, sir.
Thank you, Nishant, and good evening, everyone. I welcome you all to join the second day of our Onco Connect Live Multi-Cancer E-Summit. And in the first session, I would like to invite Dr. Jitendra Kumar, and he will be discussing on the lens of CNS 2025. So, over to you, Dr. Jitendra.
Thank you, sir, for the opportunity. Uh, uh, can somebody share my slides? Okay, so there are three abstract in the lung space which were presented at this ASCO in 2025. One abstract, I have 15 minutes, so I will try to complete everything, and three abstract, each abstract will need 5 minutes. So these all abstracts are using the same uh, adjuvant palliative molecules in the neoadjuvant space. So we will see how this data comes through. So the first abstract what we have, that immunotherapy and chemotherapy in resectable non-small cell lung cancer. The checkmate 816 overall survival data. Next slide. So this was the pre-planned five-year analysis of checkmate 816, and in this Nivo and chemo was given to the patient as a neoadjuvant regimen, and it did benefited in lung cancer specific survival versus chemo, and it was the effect was durable. The long-term EFS was there when Nivo was added to chemotherapy. So patient with PET-CR following chemo or Nivo plus chemo had improved overall survival, and when we compare with or without PCR, pre-surgical CTD clearance was associated with improved overall survival. Next slide. So this was a checkmate 816 study. It was a phase 3 study in which patient who had a resectable non-small lung cancer, Nivo chemo was given, and it was the only approved chemotherapy regimen in US, Europe, and several other countries. So this data is published, submitted, presented in ASCO 2025. Next slide. So this was a study design. As we can see that resectable non-small cell lung cancer size should be more than 4 centimeter, PS 0 to 1, stratified as stage 1B, 2 versus 3A, PDL1 stratification there, and sex. So here we can see Nivo chemo 3 cycle, 3 weekly chemo followed by chemo 3 cycle in both the arms, surgery within 6 weeks of the chemo, and adjuvant chemo RT as per the standard recommendation. So the minimum median follow-up was 59 months and the median follow-up was 68 months. The primary endpoint was PCR, EFS, and the key secondary endpoint was OS, which we are discussing today. Next slide. So PCR and EFS for Nivo versus chemo in the primary analysis population were to be tested with 1% and 4% type of error. This was the statistical analysis plan. If PCR was statistically significant, EFS was to be tested with a two-sided type 1 error of 5%. This is the standard formula which we usually do in a secondary interim analysis. If PCR and EFS were both significant, OS was to be tested hierarchically with a two-sided type 1 error of 5%. So OS final analysis was pre-specified to occur at 185 events or 5 year. So this was a 5-year presentation. Next slide. So this is the final OS analysis. As we can see in the Nivo chemo arm, the final OS was not reached. The median OS was not reached. In the chemo alone arm, it was 73 months. And if you can see, there was an absolute difference of 10% in the whole of the population at 5 years. Next slide. And this is the subsequent therapy in the patient who had progressed. So in Nivo Kivo arm, 31% of the patient did receive some sort of therapy, which included radiotherapy, surgery again, systemic chemotherapy, immunotherapy. And as we can see that chemotherapy were more given in the chemo arm, as well as radiotherapy was also given more in the subsequent arm of chemotherapy because there were more relapses, 92 versus 56. Next slide. So this is the Kaplan. This is the forest plot. As we can see, everything was probably favoring the Nivo chemo arm, but the confidence intervals was not met except for the whole group. But still, we can see that majority of the places like stage 3A, like PDL1 more than 50%, 1 to 49% were favoring the Nivo chemo arm. Next slide. This is the subgroup analysis. As we can see that although hazard ratio was 0.77 in early stage disease also, but confidence interval probably due to the lower number of the patient was more than one. Next slide. So as we can see that in PDL level expression less than 1%, the curve were almost parallel and near to each other, and PDL1 more than 1%, it was 58 versus 78%, 20% difference if PDL1 expression was there. Next slide. So coming to the lung cancer specific survival at 5 years, 75% patients in the Nivo chemo arm versus 65% in the chemo alone arm were having a survival advantage. Next slide. So this is the EFS analysis. 49% was disease-free or event-free at 5 year in Nivo chemo arm versus 34%. So additional 5% patient were disease-free when we compare with. And if you can see, there is doubling of event-free survival if you add 3 doses of Nivo to the standard chemotherapy, 59 versus 21.1 months. Next slide. So this was the exploratory analysis by OS by PCR. As we can see that upper two graph, if you see the patient received chemo, nemo or chemo, the curve was almost flattened. Although there was more survival when patient had CR on chemo, but those patients were very few. And chemo immuno patients did fare better. If patient didn't have a PCR, then probably survival outcome was not better. Next slide. So similarly, EFS by PCR. So as we can see that chemo and Nivo chemo, when it was given along with and PCR was achieved, there was better EFS when we compare to there was no PCR. Next slide. So this is about the ctDNA clearance. We do all know that ctDNA does give us early progression, but here we can see that ctDNA patients who had clearance before surgery, there was a better survival advantage when we give neo chemo or it was with chemo, and when we compare with the patient who did not have a ctDNA clearance, whether we give neo chemo or chemo. So it does garland a poor prognosis, but what to do if ctDNA is positive? That is a question still remaining. Next slide. So the safety summary, as we all know, that chemoimmuno is a safe drug. Immune-related side effects are more, so probably grade 1 to grade side effects are more when we compare with chemotherapy 11. And there was no new safety signal were there. Next slide. So coming to the summary, this was a pre-plan and final 5 year analysis of Checkmate 816. Nivo chemo demonstrated a statistically significant and meaningful OS with 28% risk reduction. 5 year OS rate was 65 versus 55 in Nivo chemo versus chemo alone, a 10% absolute benefit. Nivo chemo showed improved lung cancer specific survival, as we also know. So patient with PET CR did have a good prognosis and outcome and 90% reduction in risk of death by 5 years. Those who were not able to achieve PCR, but who did not achieve a PCR, that is a question what we should do. Maybe something like breast, what we do in breast, if PCR is not there, probably that will be coming in the future. So this is the only phase 3 trial of neoadjuvant only chemoimmunotherapy to demonstrate a statistically significant OS benefit across any resectable solid tumor type and affirm a paradigmatic shift in the treatment of a resectable NSCLC. Next slide. Coming to the next study, this is a neo-ADURA study. As we all know that osimertinib is the drug of choice which given overall survival when we compare with the standard chemotherapy. So now we are doing it in a neoadjuvant setting in EGFR mutated patient. So this was presented in this ASCO by Jamie E. Shaft, and this study had an interim analysis which was presented here. Next slide. So here this is a three-arm study. Next slide. So here so the back coming to the background, what we were coming to know that more effective neoadjuvant treatment were needed for neoadjuvant patient, and we do know that adding immuno in EGFR mutated patient doesn't work. So patient who derive survival benefit of adjuvant osimertinib. So thus this lead to that neoadjuvant osimertinib can give us benefit. Next slide. So this is a global randomized phase 3 study. Patient who has age 18 or more, uh, non-squamous NSCLC exon 19 L858R patients, PS0 to 1 stratified into three arms: osimertinib alone, osimertinib along with chemotherapy, and chemotherapy alone. After 9 weeks, they were subjected to surgery, and after that, investigator choice of adjuvant treatment was given. Major pathological response was the primary endpoint. Next slide. Next slide. So these were the best. Next slide. So almost 100 patients in each arm, and they were well matched. ALAT58R and exon 19 both were almost 50% in both the arm. So this is a surgery summary. We can see that OC monotherapy was leading to 97% patient who underwent surgery. Probably OC and chemo, some sort of side effects might be there, and the full data has to be come up, and that lead to probably a lesser chances of surgery, and chemo definitely the lesser chances of surgery probably due to progression which lead to decreased surgery. Almost 90% plus R0 reduction in patient who underwent surgery. Next slide. So reason for not undergoing surgery is that patient who had adverse effect or progressive disease were more like 8% did progress in chemotherapy arm, 2% in OC, and OC along with chemotherapy arm. Next slide. So coming to the major pathological response, which was 2% in the chemo arm, versus if you give chemo along with uh, OC, which was 28%, 26%, and OC monotherapy alone was 25%. So there was a difference in the major pathological response, which were this here. Next slide. Coming to the forest plot, when we compare on the right of you, that OC with chemotherapy or placebo with chemotherapy, it did favored the osimertinib arm. Similarly, if you compare it with OC monotherapy with chemotherapy, it favored osimertinib arm. Next slide. So as we can see by this waterfall curve, there was definitely deeper response when we gave osimertinib alone or with chemotherapy, and there were decrease or limited chances of progression when we give osimertinib in such patient. Next slide. So this is the second exploratory analysis where N2 disease regression was seen. So in 21% patient only when we give chemotherapy, there was decrease in the surgery of N2 disease. If you give OC or OC with chemotherapy, almost half of the patient did have N2 downstaging. Next slide. So this is interim EFS, as I was telling that there is lesser amount of data available here. So as we can see, patient who received is osimertinib, the interim EFS at 1 year was 95% versus 83%. So 10% absolute difference was there, and there is 27% decrease in the risk of progression were seen. And if you give OC, so the data is about to mature, and probably we will see the final analysis next time. Next slide. So this is about the MPR status. If patient had a good major pathological response, the curves are usually flat. If MPR is negative, that we all know probably with the time that whatever good therapy will give, response is one more criteria where we can suggest the that this will probably guide us regarding the prognosis. Next slide. So this is the safety summary. All the side effects are probably well managed, and the probable side effect which we can have with osimertinib, like skin toxicity or diarrhea, which were more in OC alone and OC with chemotherapy. Otherwise, the combination we all are using in our routine practice, that we can give this chemotherapy agent along with EGFR TKI. Next slide. So this bar diagram shows us that diarrhea was the most common side effect, followed by constipation, cough, rash was there around 10% patient, and similar side effect was seen, although slightly more when we give the same thing along with chemotherapy. Next slide. So coming to the conclusion, neoadjuvant osimertinib with or without chemotherapy demonstrated a significantly improved MPR rates, 26% and 25% versus 2%. Interim ES is significant with HR ratio of 0.73. Fewer patients with an MPR had a EFS event versus patient without an MPR. Overall, 50% of patients with baseline N2 disease were downstage at surgery with OC containing arm versus 21%. Safety finding was consistent with the known profile of the individual agent. Next slide. Coming to the third agent, in the small cell space, we know that Atezio and etoplatin is the standard agent in extensive stage lung disease. But now probably we are going towards adding another alkylator to the continuation of atezolizumab if the patient is progressing. So we are selecting the patient who are benefiting, and then we are adding another alkylator called lurbinectedin, which is approved in US for small cell lung cancer. So this is the IM Forte phase 3 study in small cell lung cancer. Next slide. So the key takeaway of this was that there was a statistically significant and clinically meaningful improvement was there when lurbinectedin was added to Atezio. The safety profile was predictable, and the combination has potential to become the new standard maintenance therapy, or probably an early second line, what we can say. Next slide. So this is the background. As we all know that first line immune check-in inhibitor plus platinum based therapy is eventually experienced as a disease progression, since the benefit was only 2 months. So due to the higher attrition rate in small cell SLC, almost 60% patients were not able to take the second line of treatment. The most effective treatment in the front line or maybe a maintenance strategy was the key to go. So lurbinectedin as an alkylating agent, which was a transcription inhibitor, was atezolizumab because it has shown synergistic effect with immune checkpoint inhibitors to achieve high rates of tumor regression. So in phase 1-2 trial with relapse small cell lung cancer, the combination of lurbinectedin and ICI was well tolerated. So this was a global open label randomized phase 3 study, and it investigated the efficacy and safety of lurbinectedin and atezolizumab. Next slide. So this was a study design. There were patients who was extensive small cell lung cancer without a brain mets, and they were given Atezio etocarbo 4-cycle Q3 weekly, and patient who did shown a response, CR, PR or stable disease to this induction regimen were randomized to either Atezio versus. So this was phase. So this was probably a continuous second line or probably a maintenance phase to a select subgroup of patients. Next slide. This is a statistical analysis plan that type 1 error rate was two-sided alpha 0.005 and IRF was PFS was alpha of 0.001. If rejected, 0.001 will be passed to overall survival. So if 0.001 was achieved, then there will be an analysis of overall survival. This was the analysis plan. Next slide. Correct. Almost 240 patients on each arm. 65% maximum were white. Asian were also there, around 12% in each arm. Liver metastasis was the most common site, around 40% in both arms. And fewer patients did received prophylactic cranial irradiation around 15%, and LDH raise was almost similar in both the arms, 70%. And time from induction therapy was around 3 months in both the arms. Response almost 87% patient did have a CRPR, and 11% patient did have a stable disease. Next slide. So, as we know that in small cell lung cancer, the graph falls suddenly. Here also the graph started falling suddenly, but there was almost at 6 months, there was PFS was almost double if you give lurbinectedin in those patients. So out of the 60 patients, probably we were able to catch up 20 more patients. So the median PFS was 5.4 months versus 2.1 months. Next slide. So we can see with the forest plot, although the graphs somewhere are crossing the midline, probably because of the smaller size again, and Etojo was a better competitor arm. So probably it was favoring slightly towards the lurbinectin and Etojo combination. Next slide. So after 12 months of randomization from after the induction chemotherapy, from the starting of Itejo and lurbinectedin, the 12 months was 56 versus 44 months, and there was almost gain of 8%, and the median overall survival was 13.21 versus 10.61. If you remember the data of Atejo itosis, probably at that point in time, the median OS was 10 versus 12 months, and here after those 3 months of induction therapy, so probably we are looking somewhere around 16 months versus 13 months. So here the gain was 3 months. So that we have to take with a pinch of salt that how to use this agent in current practice. Next slide.
Sorry to interrupt you, sir. Please conclude
I
your
will
talk.
just finish up in 2 minutes. Next slide. So this was a similar slide, and here they have added 3.2 months to the overall survival calculation. Next slide. So this is the OS subgroup analysis, and this is probably crossing or in near to the midline. Next slide. So this is the duration response, and probably the difference in over response rate was around 9%. And did Liberatectin added did give them benefit, but probably that was not that was magically probably which was expected. Next slide. So subsequent anti-cancer treatment was chemotherapy, majority immuno was given in both the arms. Probably chemo was given more, and there were no target. Slide. So safety summary, there were no safety signals, and probably the chemo-related side effects are more when we are adding an alkylator like neutropenia and fatigue, and grade 5 AI was seen in 5% patient in the lurbinectedin arm versus atezolizumab arm. Next slide. So as we know that nausea, anemia, fatigue, appetite loss, and low platelet diarrhea were more seen in when you add an alkylator. Next slide. So coming to the conclusion that stratified IRF PFS was better if you add an alkylator, which is the hazard ratio of 0.54. Stratified OS was also better, but p-value was not that much significant. OS benefit with lurbinectin and atezolizumab was generally considered across the majority of subgroup. Despite the higher grade 3-4 side effect, there were no new safety unexpected signal with lurbinectin and atezolizumab, and which was probably the side effect profile was predictable. And it is the first phase 3 study to show a PFS and OS employment beyond atezolizumab, which was seen. Next slide. So this is all. We had trial in neoadjuvant immuno, neoadjuvant EGFR inhibitor, and SCLC inhibitor. So just a brief that probably neoadjuvant neo chemo, if you had a resectable patient, probably is the way to go. And neoadjuvant EGFR inhibitor is looking promising, but we can wait for OS survival analysis. Small cell lung cancer space, probably we need more improvement in the coming future. Over to the organizer.
Thank you, Dr. Jitendra, for giving an expert idea from the ESCO 2025 about the role of neoadjuvant immunotherapy and the neoadjuvant osimertinib in the resectable lung cancer, and giving us idea about the role of lurbinectedin in the maintenance treatment of the small cell lung carcinoma. So, in the continuation of this, in the next session, I would like to invite Dr. Aparna from Delhi. She will be discussing about the decoding the alphabet myths in the NGS. So over to Dr. Aparna ma'am.
Hi, good evening, everybody. Thank you, Dr. Sachin and organizers for having me here today. Very quickly, can you see my slides?
Yes, we can see.
All right, perfect. So good evening, everyone. So I've got quite the task set for me today. I'm going to be essentially walking you through, a lot of NGS partners are there. How do we read a report? What is a good, bad, ugly NGS? Just some of the nuances is what I'm going to be taking you through for the next 10, 15 minutes. So we have a lot of testing options, we know that, but what's been brilliant is that as time has evolved, as research has evolved, we've gone ahead and we've started focusing more on doing next generation sequencing because we've realized that, honestly, looking at multiple genes, getting a 360 view of the tumor is becoming far more beneficial in our treatment, in our treatment options for our patients. And the sample types that are available is tissue, when tissue is an issue, liquid biopsies, usually in the metastatic setting for most cancers, and in lung cancers, we can start as low as stage 3B is when we can actually use liquid if tissue is an issue. And liquid's role has also evolved. ctDNA, we've got MRD testing, we've got we've got early detection prior to diagnosis. So there's a lot of great stuff happening with ctDNA. But for today, we're just going to focus on tissue and liquid being our two test samples for doing this testing. Now, we've got a lot of molecular test modalities that are available. So I'm not going to belittle the standard of care and say that this is not good or that is not good. They're all good. They all have their plus points and they all have their negatives. But what's most important is, and why NGS has fast become the platform of choice is, in one shot, you can actually get a 360-degree view of the various somatic aberrations that are happening in a gene, which can help with treatment analysis. Yes, at times when the quality is not great of next generation sequencing, we do tend to go back and use other orthogonal methods like FISH, IHC. Some things can only be done on IHC, for example, PDL1, or in some cases, we go back and we'll maybe run an RT-PCR just to be 100% sure, especially when we're doubtful. So that's why, yes, NGS is our favorite. It tells us everything at one point. However, when in doubt, we do go back to our other platforms. Now, these are some of the panels that are available today, the somatic panels. We have very rarely, but once in a way, we do single gene testing when we're looking at one gene. Usually, this is more with germline when we're looking at doing Sanger mutation testing for a known pathogenic or a familial mutation. But I think we've evolved. Today, even our organ-specific tissue testing is, it used to be hotspot, but I do know a lot of panels now that are going beyond hotspot and doing a full gene coverage, even in the small organ, lung-specific ones, colorectal, breast, gynac, or even endometrial. And they usually do DNA, but now some panels are also doing RNA. Now, we do know that whenever you're looking for a fusion, the ideal NGS should be DNA and RNA. RNA has a far more higher sensitivity in calling out fusions. And with agnostic markers like NTRK, RET, ensuring RNA is there right from the most smallest panel, I think has become really important. And you'll actually find this information on the second, third page of your NGS report under test methodology, where they'll say if they've used DNA, RNA, or sometimes the language used is total nucleic acid. Now, so we have those as organ specific. Then around we have those 50G panels, which are your small panels, which are again good. They give you your MSI, they give you your CNVs, your copy number losses and gains. The medium panel is around 70 to 100. Again, over here, pretty similar, just a bit of more genes. The larger panels are 100, 150, but what really stands out is CGP, which is more than 200. And here's where you get all your other assays. You get your HRD signature, the genomic instability, the methylation signatures, great work there, MSI, TMB. And if you see, I didn't mention any of these TMBs and all earlier, because in order to report tumor mutation burden, you need to have a minimum 200 to 300 genes on your panel. So these are the type of panels that are available. And why am I talking about this? Because it's important knowing what you're testing for and what the panel covers. Quick recap, CGP versus hotspot. CGP is comprehensive genomic profiling, which means that every part of the coding region, which is the exon, is covered. Hotspot, we don't look at all the exons. And again, within the exons, we just look at certain codons, which are the most commonly or frequently mutated, which means that you end up missing out on those less common mutations, which could have therapeutic implications. So going back, even in your smaller panels, ask your laboratory, because I think somewhere we have gone ahead and we're not really sticking on hotspots, that even in the small panels, it's not CGP, but at least they're looking at the complete gene. Ask your laboratory this. So when you have to choose a test, how do you figure it out? And especially with the diagnostic lab. So you need to see, what are you testing for? Does a small panel suffice? If not, is it one of those rarer cancers where maybe doing CGP testing may be more beneficial? Now, if I'm just looking for HER2, I do know FISH might be a better option, or even IHC, as a matter of fact. So what am I looking for? What is my goal is the question that you always need to ask yourself when you're doing any sort of molecular testing. Now, a lot of laboratories are there and everybody says my test is better than that person's test. I do 500 genes, I do 700 genes, I do this and I do that. So a couple of things to look for. Accreditations and approvals don't get swayed with CAP, don't get swayed with NABL. What you really need to look is at their process and their validation robustness. Was any clinical and analytical validation done? Not on 10 samples or 20 samples. It has to be a decent cohort of at least 100, 150. How many were used, all these samples, and all this data that they have collected and validating, was it published? Good laboratories in India too do publish their validation in reputed journals. And more importantly, what are the parameters? What is the depth of coverage? Ideally, somatic testing should be 500x. Sometimes, because of cost constraints, they bring it down to 250x. But I do know some labs even do it at 100x, which is a big no-no. It's a huge red flag. Again, go to the test methodology page and see the depth of sequencing. In germline, 100x suffices, but when we're doing somatic, ideally 500, if not 500, 250 is the lowest that one can go. And who is doing the test? Are they dependent on some bioinformatics pipeline, that the laboratory, that the assay has given them, that Thermo Fisher or Illumina has given them, or is there actually a proper bioinformatician who's calling out these mutations? Extremely, extremely important. If it's just dependent on the assay and on this AI system that is built in, I would run in the opposite direction. It's very important knowing who is the scientific team and how competent and how experienced they are in calling out these mutations. Now, I'm going to give you a very simple example. This is back in the day, super old, on the BioCartis IDELA machine. We had done an NGS. We had done EGFR testing. No mutation was detected. Patient landed up in our hospital. When the patient landed up in our hospital, obviously this was a hotspot panel. I did testing. And we did liquid biopsy because it was insufficient. The tumor and the patient refused to have a rebiopsy. And this exon 19 deletion was missed. Now, the patient obviously was livid. And so was a medical oncologist at the previous institute that they started fighting with the laboratory that did this EGFR mutation. It's not their fault. That particular mutation that Garden picked up is not on the panel of the IDELA BioCartis. That was a hotspot panel. While yes, this was an exon 19 deletion, but look at the proteins. It wasn't your classical 745 or 750. It's actually your 747, 755. So the proteins were different, and that's why it got missed. So be very careful what you're ordering for. And, back in the day when, we were reporting EGFR, there was a lovely paper back in 2014 where they compared various laboratories this was done under ESMO, and this was across Europe, those accredited laboratories, and they saw even over there the rates were as high as 37% in reporting basic EGFR. So we've evolved, and from there we realized quality assurances were needed. We needed to put checkpoints in place, and that's where the American Molecular Pathology team came out with these guidelines, where they very beautifully stratified various somatic aberrations into tier 1, tier 2, tier 3, and tier 4 mutations. And based on that, these reports were, and based on that, a report was to be presented. Tier 1 had level 1A and level B. Level 1A essentially was you found a mutation which had a targeted therapy for the tumor type that you were testing for. Level 1B was you found a mutation, but there is targeted therapy, but not for the tumor type you're testing for. And then you've got level 2, which is, tier 2, which is, you do have FDA approved therapies, maybe different tumor types, or maybe it's not well published. So there were different tiers that were available. What's interesting is tier 3 is your VUS. And interestingly, in somatic, a lot of VUSs do get reclassified as tier 1. So always be in touch with your laboratory. And this is what ESMO eventually went ahead and divided these classifications into tier 1, tier 2, tier 3, etc. And this is what we follow when we report. Now, again, what is the best test? We do know RNA sequencing is superior than DNA sequencing for fusions. So this was an excellent paper with the MSKCC group, and they retrospectively looked at data where in adenocarcinoma and SCLC non-smokers, the NGS had come back negative. So they ran it on the DNA sequencing panel of theirs, and they found a 14% of mutations, fusions in particular, that were missed out on DNA was actually picked up here. And look at that. These are all actionable. These are just some of the rearrangements. They're all actionable. So DNA plus RNA is extremely essential. Now, when we're doing liquid biopsies, be careful of CHIP variants. CHIP are clonal hematopoiesis of indeterminate potential, which means that sometimes when we're isolating the ctDNA, we do get junk that we pick up from other normal cells. And these are all WBCs. In smokers, we tend to see more. In old age individuals, we tend to see more of these. These you will find with TP53, JAK2, and they have very, very low, VAFs, like 0.01. Be careful when you're looking at them. Don't always think that they're actionable. Go back with the laboratory and get them to confirm if it's a CHIP, but majority of the time they can be CHIP mutations. Now, in the era of somatic testing, we are going to be picking up germline findings, and I can't stress how important it is upfront to counsel your patient when you're doing somatic testing. We've been burnt. We've had to deal with a lot of irritated, a lot of anxious patients because breaking the news after A, dealing with the fact you have the disease. B, you pick up a germline mutation. You went looking for therapy and you found that it could be potentially hereditary. So it can be very stressful for a family. So upfront, educate your family about this, that there is a potential, especially with those HBOC-associated cancers. And obviously, before we go ahead and we say, oh, yeah, this is germline, make sure that you double check and quadruple check if the germline is truly a germline. Now, just because a report has come, do not take it at face value. That's not the holy grail. Go back and check, double check, quadruple check. And guess what? There are a lot of websites that are available that are free where you can go back, punch in those mutations that your NGS report has and check the validity of those reports. And that's the same what even the ESMO guidelines have. And these are very well documented. I genuinely go back here and I check every gene, every mutation that is on an NGS report, no matter if it's FDA approved testing or it's a domestic partner. Check, double check. Now, some of the things that you will see in your NGS report, some of the words that you need to be familiar with is the classes. Now, when we do germline testing, we use ACMG guidelines. If in your somatic report, someone says, as per ACMG, this is pathogenic, that is a huge red flag. In somatic, we report as per AMP guidelines. So that's number one, that's important. Number two, the type of mutation. Is it a copy number variation? Is it a gain? Is it a loss? Has to be reported. Is it the zygosity? Is it heterozygous, homozygous? Is it a deletion? Is it a deletion which has an insertion? Is it duplication? Frame shift, insertion, everything should be very categorically mentioned over here. The variant allele frequency should also be mentioned, and if it is a non-pathogenic. If it's a VUS, it should be very categorically stated. Now, in addition to that, a good NGS report should have good demographics with respect to a patient, right? So the patient's date of birth, gender, name, if the specimen type, the tumor, where is it taken from, tumor content, in the case of liquid biopsy, the tumor fraction, when was the blood sample collected? All of this needs to be very clearly documented over here. Then the results. Everything should be in a very non-ambiguous, very clear way. It should be mentioned, what is the testing, what is the limit of detection, and if you are calling something positive, what is the data available that supports you calling this positive? What are the various databases you've used? What are the in silico, bioinformatics pipelines that you've used in calling something positive? All of this should be very, very well documented. And this is just a very nice, clean way. I know it looks a little messy right now, but this is what this is just an example of a good NGS report from ESMO, where everything is very, very clearly mentioned. Again, a couple of these that we do tend to see day to day in our clinic, where everything is very clearly documented. Look at this foundation report here. It's telling you it's a block. It's telling you the specimen site. So it's very clearly mentioned here. You have a liquid biopsy from Guardant, where it's telling you when did they collect the sample, what type of, it was obviously a blood sample, when did they receive it, when did they report it? It's mentioned. Similarly over here with the germline testing. Now see, this is a germline report. It's a BRCA2 mutation, and see how lovely, how beautiful this is of how they're explaining as to why this is a pathogenic mutation, why I should take it seriously. And they've given all the data points that I can just go into, double check and cross check if this is a true mutation.
I'm sorry to interrupt you. We are running short of time. Please conclude your talk in next 2 minutes.
Yeah. So here is, and when we obviously have a lot happening with all these reports, it can get confusing, and nothing works better than a molecular tumor board. A molecular tumor board is a multidisciplinary approach where you have people like genetic counselors, molecular geneticists. All of us are available. We're all a call away if you don't run a tumor board. Call us and we're always happy to help. Very quickly to walk you through some of the common errors. So this was a patient of mine who had a very strong family history of Lynch. We did MMR testing, MLH1 and PMS2 was lost. So we sent it for germline testing, and this came back as a VUS. I thought it was really weird. I checked on the databases. This was pathogenic. The lab, for whatever reason, refused to listen. So then I retested it in another laboratory, and lo and behold, it came back positive. It is a known pathogenic mutation. So lesson learned, check. Don't just take things at face value. Now, 59-year-old male, NSCLC, non-smoker. We did NGS and PD-L1. This patient was done, this was tested somewhere else. And look at the testing. This was a TMB panel that was done. That is wrong. TMB panel is designed, that assay in particular is for calling out the tumor mutation burden. Its sensitivity in picking up mutations is not great. But anyways, they still did it. And look, over here, you had a TP53 and a RET. The physician saw this and started with selpercatinib. The patient had a massive progression. Lesson number 2. Lesson 1, testing was wrong. Lesson 2, RET, you only act on fusions. There's only that one common RET fusion, the one, I forget the number right now, I've just blanked out, but there is a point mutation where that's the only exception. It's definitely not this one. And in that case, it should not have been treated with selpercatinib, but anyway, the patient was even made to do germline testing because of the high VAF. But when we got this patient, we went and checked the databases. This particular RET mutation is benign. And as per the somatic variant, it's again benign. So we shouldn't have tested this. The patient obviously progressed on selpercatinib. This was the germline report, which was negative. Then we went for testing, and it was such a simple 746, a very classical exon 19 deletion. And the patient was immediately started on was immediately started on OSI with chemo because of the TP53. And in addition, because of the TP53 and the RB1, we are monitoring this patient for a potential small cell transformation in the future. Now, again, double check, triple check. NTRK point mutation, we went back, checked, it was really high, 99.9. We're like, whoa, this doesn't look right. Could this be a possible racipathy from a germline indication? Checked it, it was actually likely benign as per germline, never reported in somatic, maybe a VUS. And this was another case where we had, a patient with a case of CA ovary. treated, was doing relatively well, and then she unfortunately had a recurrence. And at this time, we sent her for somatic testing, picked up a BRCA1 and a TP53. This BRCA1 was a known germline event, so we had to send her for hereditary testing, and it was so difficult telling her. She was anyway upset that the result, the fact that her cancer came back. And it's, I think, henceforth that we learned that if there's going to be BRCA or any of these potential germline mutations that can be picked up on these somatic tests, we forewarn a patient up front. And to sum it up, these are just a couple of the things. This is my approach. It's not the right approach, a wrong approach. I don't know. This is just my approach, what I do when I'm interpreting an NGS report. Maybe you could take a screenshot of it. And these are just some of the factors to keep in mind when you are recommending any off-label therapy. Please remember, when we are doing molecular guided therapy, it's precision oncology is the right treatment for the right patient at the right time. And sometimes the right treatment can be wait and watch. Sometimes it can be chemotherapy. Sometimes it can be radiation, surgery. It doesn't always have to be, a concoction of multiple drugs. So keeping all this in mind, thank you so much for your patient listening. I'm going to stop sharing, and I'm happy to answer any questions, if any.
Thank you, Dr. Aparna, for giving a very good insight in how to use NGS. Basically, we as a clinician generally want the CRT in unresectable stage 3, EGFR and SCLC. So over to Dr.
Yes, a very good evening to you, Dr. Sachin sir, and thank you for the opportunity. I'll just share my slide.
Please, Baba. Please,
I hope it's visible.
please.
Yes, sir, visible.
Okay.
Please,
So
please,
my
please,
topic
please.
is osimertinib after definitive CTRT in unresectable stage 3 EGFR mutated NSCLC. That is the LAURA trial. So we all know that 1 in the 4 patients present with stage 3 disease. So stage 3 locally advanced NSCLC is a heterogeneous disease with majority of patients having unresectable tumor. So most of them comes in stage 3A, 3B and 3C. We all know how the staging of 3A, 3B, 3B and 3C differentiate. Mostly in 3A we have up to T1, T2 with N1, N2, and then we have T3, T4, N1 and T4, N0. With 3B we have T3, T4, N2 and we have T1, T2 up to N3, and with 3C, any T4 with N3 singly will come to stage 3C. So this is how the subdivision of stages of lung cancer. I don't need to read out in particular. So for stage 3A, can be incidental finding. They are potentially resectable, potential resectable with risk of incomplete resection. And some of the stage 3 we having different subtypes can also be unresectable. Stage 3B and 3C are mostly considered to be unresectable. So the majority of the lung cancers are diagnosed as unresectable stage 3 or stage 4 NSCLC, which are associated with poor prognosis. 85% of the lung cancer are mostly NSCLC and rest 10 to 15% are small cell and other variety. So out of that, 25 to 40% of patients with NSCLC presents with locally advanced disease, and approximately 30% of the patients present with locally advanced disease that is unresectable, and that is stage 3A and 3B. So stage 3C is definitely unresectable, but out of A and B, approximately 30% of the patients are still unresectable. So if we compare with the 5-year survival rate, with 3A it is 36%, with 3B it is 26%, and with 3C is very less, that is 13%. So whenever we do a management of stage 3 locally advanced NSCLC, we need to find out whether there is a chance of resection, or whether there is a possibility of concurrent CTRT or any scope of neoadjuvant chemotherapy, and nowadays also the role of neoadjuvant immunotherapy. So any of the stage 3, we need to involve a multidisciplinary team action, which is consisting of a pathologist to confirm the pathological staging, radiation oncologist, medical oncologist, a pulmonologist, and a thoracic surgeon to find out whether the patient is fit for the surgery or not. So after doing the pulmonary function testing, bronchoscopy and PET scan, pathologic medicinal node evaluation, and brain MRI with contrast. These are the basic diagnostic and pre-treatment evaluation needs to be done before starting the treatment for any stage 3 lung cancer. So definition of curative CTRT is a standard of care for stage 3 unresectable NSCLC. So these are the basic difference in the various guidelines. With NCCN, with stage 3A, that is T4N01 unresectable, we go with definitive CTRT. With stage 3B, that is N3N2, we go definitive CTRT, and the stage 3C, that is T3N3 or T4N3, we go with definitive CTRT. So especially in stage 3B, if the only possibility of surgery is when the node is less than 3 centimeter, there is a single node, well-defined lesion, then only we can give neoadjuvant chemo followed by surgery can be attempted. Otherwise, most of the patients of stage 3B with a larger node or multiple node mostly goes towards CTRT. And same is being followed with ESMO guidelines as well as the ASCO guidelines. So the concurrent CTRT has been the standard of care since 1990, and there are various clinical trials which have been done to establish the role of it, in which we have EORTC trial, which have compared the daily cisplatin with weekly, and we all know that the most commonly we use the weekly cisplatin. Then Jeremic et al. Have tried various fractionation differentiation of radiotherapy, showing the potential benefit. Uh, Along with the Jeremic et al. Has tried it with carboplatin etoposide, giving us good results. So mostly in unresectable NSCLC stage 3B, 3C, the outcomes of CTRT is much better with a significant p-value of survival benefit. So concurrent CTRTs have been shown to provide patients with a greater clinical benefit compared with sequential treatment. So we use sequential treatment mostly in patients which are not fit, and we need to tone down the disease, and patients are very frail. In those cases, only we give chemo followed by RT. Otherwise, CTRT is always been preferred. So retrospective comparison between sequential and concurrent CRT at one institution between 03 to 2010, the outcomes with sequential CTRT was 17.4 months, the median OS, whereas with concurrent CTRT, it is 18.6 months with a higher 5-year survival rate. And we can clearly see in the diagram, the bar diagram showing that the red color shows up for concurrent CTRT, and both in OS and PFS, 5-year, the CTRT has been showed superior results as compared to induction chemo followed by RT. So for those in whom CRT is not possible, that is a frail patient, sequential chemo followed by definitive radiation is an appropriate alternative. So what is the unmet need in unresectable stage 3 EGFR mutated NSCLC? So previously, around 4 5 years back, after the CTRT, and even in EGFR mutated, we usually go with the follow-up or durvalumab if PDL1 is positive. Otherwise, in almost patients, all the other patients, we keep on observing. So in unresectable stage 3, following CTRT without progression, standard of care is consolidation durvalumab, and benefit of consolidation durvalumab in Pacific trial we all know is uncertain based on Pacific post hoc subgroup analysis. So efficacy of EGFR TKI is supported by phase 2 result study and the real world data, but prospective phase 3 data was still missing. So no approved target therapy initially was there a few years back for stage 3 post CTRT in EGFR mutated NSCLC. So then comes a very important trial by the name of FLORA, which is a phase 3 double-blind study design. And patients with locally advanced unresectable stage 3 EDFR mutated NSCLC with no progression during or following definitive CTRT. The key inclusion criteria are greater than 18 years of age, with confirmed locally advanced unresectable stage 3 NSCLC, exon 19 deletion, L858R substitution mutation, and with a maximum interval between the last dose of CTRT and randomization is 6 weeks. So the randomized arms are osimertinib 80 mg daily after CTRT along with placebo once daily. So treatment duration until blinded independent central review assess progression, or if there is any toxicity discontinuation. And the tumor assessment was done by radiologically by CT, MRI brain, and the points when it was considered at the baseline every 8 week to week 48, and then every 12 week until BACR assessed the progression. So the primary endpoint were PFS, and the secondary endpoints were OS, CNS PFS, and the safety. So this is the baseline demographic characteristics comparing the how many male females, the median age, the smoking history, the how many EGFR mutated, the type of RT that is concurrent or sequential, and the response to the prior CTRT. So the key takeaway from the slide is that baseline characteristics are well balanced between osimertinib and placebo group. This indicates that demographic disease features and prior treatments were comparable, ensuring that any observed differences in outcomes are likely due to the study treatment. So we can clearly see the difference of osimertinib is much higher as compared to the placebo. And the well good separation of the graph in 2 months is the difference is 65% versus 13%, which is quite a remarkable difference. And that clearly shown how beneficial the adjuvant osimertinib in EGFR mutated unresectable post CTRT and SCLC can be. So the progression-free survival was 13.39 months versus 5 months, which is extremely superb with a great hazard ratio and significant p-value. Um, and the progression-free survival with blinded independent central review and investigator assessment also shows the similar results with the great benefit of PFS. Because even during the first year, we can see the early separation of the curve and it widens maximum at the 2 years, and still the separation is maintained up to the 5 years. So that shows how wonderful the adjuvant osimertinib has worked in this patient. So the progression for survival across the all group. So we all know that in EGFR mutation and in concurrent in almost all the groups, the adjuvant osimertinib has been favored. So it is consistent and significantly improved PFS across all tested patient subgroups, regardless of demographic, disease characteristics, or prior treatment. So again, this is the graph showing the tumor response, and we can clearly see in the comparison, the objective response rate of osimertinib was 57%, the disease control rate was 89%, and the median duration of response in month was approximately 36 months, that is almost nearly 3 years. So which is a remarkable achievement by adjuvant osimertinib. Yeah. So this slide show that how do we compare osimertinib versus placebo in view of development of new lesions. So if we compare that only 22% patients develop new lesions on adjuvant osimertinib post CTRT, whereas 68% patients on placebo has developed new lesions, that is progression disease, and in which the brain lesions are only 8% versus 29, and that goes followed by lung, liver, lymph nodes, bone, adrenal, omental, pelvic, spleen, and others. So even in the development of new lesions, osimertinib decreases the chance significantly, especially the brain and lung. So the interim analysis of overall survival, 81% of the patient of the patient with BICR confirmed progression crossover to osimertinib because of the excellent response shown by adjuvant osimertinib. So these are the adverse effects, and no any significant toxicity has been noticed. So significantly longer treatment exposure, less interruption of the drug, and adverse events were generally manageable with low rate of adverse events leading to discontinuation. Even in my clinical practice, osimertinib is one of the most easily tolerable TKI, and the same is being depicted in LAURA trial. So all the most common adverse effects in both the arms were radiation pneumonitis. The majority were low grade and no serious uh, and manageable. This is what this diagram depicts. So radiation pneumonitis was common but mostly low grade in both the groups, while osimertinib shows higher rates of characteristic EGFR TKI like diarrhea and rash, which are quite manageable with oral antibiotics and oral antidiarrheal support. So in conclusion, the unmet need, there is no approved target therapy for unresectable stage 3 EGFR mutated NSCLC, and the benefit of consolidation durvalumab in this specific subgroup is uncertain based on specific post hoc analysis. So EGFR mutation testing is critical in stage 3 disease to ensure optimal outcomes for patients with EGFR mutated NSCLC. As per NCCN guidelines, now we do from stage 1B onwards. Osimertinib demonstrated a statistically significant and clinically meaningful improvement in PFS in both BICR group and all the other subgroups. The median PFS was 39 months versus 5.6 months, and it was consistent across all subgroups. While OS showed a positive trend, it was impacted by substantial crossover from placebo to osimertinib, and the safety profile of osimertinib post CTRT was as expected and manageable. So it is a new standard of care. I think for 3 years is a duration as per the NCCN guidelines for adjuvant osimertinib in unresectable EGFR mutated stage 3 NSCLC. Yeah, thank you so much.
Thank you, Dr. Pulkit Nag, for very nicely presentation about the role of osimertinib after definitive CTRT. Many times we think what we should do after the definitive CTRT in unresectable cases. Now there is a new target is available as per the LOA trial, and very good several benefit with osimertinib. So
Yeah,
now,
it is quite significant also.
yeah, and so we go to the next topic, that is the management of oligometastatic disease lung cancer, and this will be moderated by Dr. Manoj Mahajan. So over to Manoj Mahajan.
Hello,
Hi,
hello.
Manoj.
Am I audible?
Yeah,
Yes,
yeah,
sir,
you are
audible.
Yes. I would like, at the outset, I would like to thank Dr. Sachin for the opportunity and quite out of the box topic to discuss with. How much time do we have, like for the moderation?
we have 30 minutes.
Okay, and I guess panelist I can see Dr. Manish and Dr. Pulkit is there.
Yes, sir. Good evening.
Good evening. Good evening.
Good evening, sir.
Good
Sir,
evening.
Dr. Pulkit is there, Dr. Manish Gautam is there, Dr. Sachin Jain is there, Dr.
Okay.
Rahul Jaiswal is joining, and rest is not available.
Okay, so we have four panelists with us. Dr. Manish, Dr. Pulkit, Dr. Sachin, and Dr. Rahul will be there.
Rahul Jaiswal is
Okay.
joining.
Yes. So we'll start with the overall concept of this oligometastatic NSCLC. I would start with Dr. Manish. Where do you place, or like the question is for all the panelists. So where do we place NSCLC oligometastatic as compared to early NSCLC, locally advanced NSCLC, and metastatic NSCLC? So in this spectrum, where do you like to fit this new entity which is emerging, oligometastatic NSCLC?
Yes, sir. It's new entity, and we can keep it into intermediate stage where it is less aggressive than the disseminated metastatic disease, but somehow poor prognostic than early stage disease. So it is intermediate stage disease, sir.
Yeah, Dr. Pulkit, as you have already shown a very poor prognosis for stage 3B, 3C. So beyond 3C, this comes in stage 4A. So what do you think where it should be placed and how we should look at it in terms of prognosis?
Sir, I think should be placed in as an early metastatic disease, and especially in case of lung, how much curative intent is still can be done for oligometastatic, I'm not very sure. So early metastatic, I would like to place for oligometastatic.
Okay. Dr. Sachin, your take on this?
Yeah, exactly same, because ultimately this is a metastatic disease, and we are saying oligo because it is less aggressive. So we can place it in a new entity like early metastatic disease, that is the oligometastatic disease.
Okay. So, do any of us practice in terms of early metastatic, or we treat? Does our intention change in this situation, like from palliative to curative, or still we are not there?
I think only in case of sir brain mets, like if it is in the category of oligometastatic and asymptomatic, then we don't address the brain mets in view of palliative and continue with the same treatment. Apart from that, I have not experienced quite a good result in case of oligometastatic and SCLC with the uh, curative intent. Might be I have not found the right patient for it.
Yes, NSCLC is as such like basically aggressive disease overall. If we compare the oligometastatic breast, it is probably
Yes.
which has quite a good variants, also good biology tumors also. If we compare with the breast, but NSCLC overall it is aggressive disease. So anyone can take up the what should be the definition of the oligometastatic NSCLC?
So
Dr.
less
Manish?
than yes, sir. So less than or equal to 5 metastasis, and in less than 3 organs. So it is the
Yes.
definition of the oligometastasis disease.
Yes, it's quite true that by the definition, but one more thing they have added, all the lesions should be amenable to the local treatment. It should not have, like, if it is not amenable to local treatment can vary. So there are basically in definition less than 5 plus 3 organs, and all the lesions should be amenable to the local treatment. One more thing I personally think it lacks is the tumor biology. It should be included in the definition. If, let's say, if we have two tumors, similarly diseases less than like 3 sites of the lesion, patient is having EGFR mutation versus patient is having KRAS mutation. So in these, what do you think, Dr. Sachin, which will be aggressive one and which will be less aggressive one?
I think KRAS is more aggressive, and as we are using EGFR mutation, is many treatment versions are available for this EGFR, so it is less aggressive.
Yes, so I think there are certain tumors which are aggressive, like KRAS, P53, STK mutation. These are the aggressive tumors, and like EGFR, ALK, MET exon 14 again is aggressive tumor. So there are certain tumors which are less aggressive as compared to other mutations which we commonly like P53, KRAS, and STK. These are the aggressive ones. So there should be inclusion in the definition uh, of oligometastatic NSCLC, where we should look at differently for different tumor biology, because not only the number but tumor biology also plays an important role in, especially in such situation, oligometastatic NSCLC. So there are always two components, rather 3 components, I'll say, for oligometastatic NSCLC. The first is the systemic therapy, which probably everybody will agree on. It has to be given in, and second component and third component would be localized treatment with surgery or localized treatment with the radiation therapy or stereotactic surgery. So how do we place all these things in a sequential manner? Dr. Manish, can you take this?
Yes, sir. We definitely look for where are the metastatic oligometastatic sites are present, and we can go through many parameters and multidisciplinary approach, and we should include other pulmonologists and radiation oncologists, and we can decide that if surgery is feasible for primary lesion, then definitely go for surgery, and if metastatic site is also surgically resectable, then we can go. But if patient's comorbidity present and pulmonary function tests are less favorable, then we can go through the combination of these, where we can use surgery at one site and radiation therapy on another side, along with the systemic therapy.
So it would be a combination of both. Dr. Pulkit, what would be the sequence you will prefer for such kind of things?
I think it depends on the site of the lesion. Suppose the
Okay.
oligometastatic site of the lesion is bone, and I'll prefer radiation because it's more non-invasive. Brain, I'll prefer radiation because systemic therapy is the backbone that we have to give. But suppose if
So
the
first would be
site is,
systemic therapy, followed by, once you assess the response, then you
and
will
then we
follow
can
the.
incorporate the palliative or the curative intent into that. But I think first has to be systemic therapy.
Okay. The one question that probably in such situation is, like, in adjuvant setting, we always give a treatment which is for limited time. It may be 2 years, 3 years. But
Yes.
in oligometastatic setting, the duration of the therapy, systemic therapy, will. So there are 2 questions of the systemic therapy. The first would be addressing it upfront. So we will be giving upfront. But how long are we going to continue? Or if we are like based on the metastatic setting until progression oblique toxicity, or we need to contain it at certain point of time. Dr. Sachin, you are more experienced in such situations, so can you just elaborate? If
Like as Dr. Pulkit also told that the systemic therapy is the main part of this oligometastatic disease, and followed by we can do if amenable to radiation therapy, and very rarely to the surgical therapy, and after that maintenance is very essential, and I think till progressive disease we should give at least some maintenance treatment to these patients.
No, I mean to say, how long are we going to continue the systemic therapy? It's like limited time or unlimited time?
Uh, After the local therapy, like systemic therapy, then
Yes, yes.
local
After
therapy, then adjuvant.
we have given systemic therapy, then patient has a good response. You have given the local therapy, patient is in CR, and now you want to make the
Yeah.
decision about the
I think this
how
is
long the systemic therapy you are going to
yeah.
give.
There is no exact guidelines how long we should give, but the only answer is till progression we should give the maintenance treatment to these patients also, because ultimately they are the metastatic patient.
Yes, Dr. Pulkit, you have any difference of opinion?
No, sir, I think I will give follow the same guidelines of systemic therapy as for metastatic disease, because it's the lung itself is a very aggressive tumor. And so if suppose if it is adeno and we are giving PEM carbo along with any immuno, then I would continue with the PEM and immuno maintenance until progression. Or if it is a squamous and we have given pecli carbo immuno, I would continue with the immuno after completion of 6 cycles of chemo, continue with the IO maintenance. So I will
Yes.
follow the guidelines same as metastatic.
Dr. Manish, you have any difference of
Yes, sir.
opinion?
No, sir. I agree with Dr. Pulkit now.
Yes, I agree. Definitely. As like the term itself is oligometastatic, so it is a systemic disease, and we have to treat it like a systemic NSCLC, metastatic NSCLC. So I think therapy should be discontinued as long as possible, as long as there is no progression or no irreversible toxicities are observed. Okay, so next slide. We'll just run through one case. So we have gathered now a few information or build the context, like what is the definition of the oligometastatic disease. The first thing in the oligometastatic thing always be a systemic therapy, followed by, if it is a responsive disease, we can give a local therapy, followed by a maintenance systemic therapy as long as possible. So quickly we'll run through 60 years, 62 years male, significant cuff and right shoulder pain since last 1 month. Smoker with history of 20 pack years, busy civil engineer and travels widely. Restricted activity due to severe pain. Next slide. Patient was found to have a lung mass and axillary lymph node. Lung mass was biopsied and it showed a poorly differentiated malignancy. Next slide. With sarcomatoid component and epithelioid component. Again, the ISC is showing the similar components, CK7 positive, Vimentin and Vimentin is positive, and SMA is positive. Hello? Hello, am I audible?
Yeah, you are.
Yes. So SMA is positive. So in conclusion, it was like CA lung with sarcomatoid variant. And PET scan was showing a lung mass with axillary lymphadenopathy. So what would be the first choice of the treatment in such situation? Patient does not have any driver mutation positive.
Yes, sir. Am I audible, sir?
Yes, yes.
Okay. So I think, sir, since CK7 is positive, which is strong, that it is mostly the marker of carcinoma. So I would go with the conventional taxane plus platin combination and would like to see the results of NGS if any targetable or any PDL1 is positive or not. If that information is not available, I would like to go ahead with the conventional taxane plus platin combination for this patient.
Okay, perfectly fine. Next slide. Next slide. So these were the PET finding: lung mass with with axillary lymph nodes and left adrenal lesion, and patient also had okay, that's 3 sites of the disease. Next slide. So it was a stage cell non-small cell carcinoma, oligometastatic by definition, and that we have seen. And next slide. So patient was given nab-paclitaxel carboplatin-based chemotherapy. And then next slide, we'll see the results. Sequencing of the treatment in oligometastatic disease that we have already discussed. Next slide. So the most probably relevant information in this situation, NGS was negative and PDL1 was 100%. So, Dr. Manish, do you have any other option open up now in
Yes,
this
sir.
situation?
I definitely want to add the immunotherapy option in along with the chemotherapy.
Okay. Next slide. So patient had symptomatic relief after one cycle. By that time, patient's PDL1 report came and patient was combined with the what everyone of us would be doing, Pembro plus nab-paclitaxel combination. Next slide. NGS test was negative. Next slide. Next slide. So we'll just have a brief oligometastatic versus systemic disease. So how do we need to compare? That is what we have already discussed. I'll just briefly point out few things. Primary tumor indolent, that will be defined by the biology or genomic phenotypes versus the systemic disease. Invasive cancer cells are sloughed in the oligometastatic disease, and systemic disease, it is actively migrating cells. Target organs are inhospitable target organs, and in systemic disease, it are hospitable target organs. Next slides. So we have already given the chemotherapy. Next slide. After PET CT after 2 cycles of chemo and IO till October 21, and subsequently patient had near complete remission. So what would be the approach for this patient? Patient had adrenal metastasis completely resolved, then complete reduction in the right axillary lymph node, and also primary lung lesion. Dr. Pulkit?
Sir, I'll continue with the same treatment because I don't, well, for adrenal mats, I don't want to add any surgery or radiation for this patient to unnecessarily complicate the thing in view of the excellent response after 2 cycles of chemo plus IO. So I will continue with the same treatment further.
Any thought process on the local therapy?
Yes, sir, but for axillary node or for adrenal mat, I mean, because even if I opt for any surgical intervention and the prior trials have not shown, it has shown good results, but not remarkable, significant good results. So I would like, because if I'll go for the local therapy or surgery and if any complication happen because of that, then the wonderful response of chemo IO can be jeopardized. So I would still, it's a gray area. I would like to continue with the chemo IO.
Yes, Dr. Manish, you have any difference of
Yes,
opinion?
sir. I complete the chemotherapy cycles and along with the immunotherapy for at least 6 cycles. Then we can decide.
Okay, Dr. Sachin?
Yeah, practically, this is absolutely right. The patient is responding to treatment very well. Then ideally, we should complete this treatment and then continue the immunotherapy.
Okay, I think panel concurs with the continuing the and completion of the chemotherapy. Next slide. So patient discussed after 4 cycles. So total complete 6 cycles of immunotherapy. PET scan again is showing the near complete remission of all sites. So it should be discussed in MDT, and that is what we are discussing. So what should be our next step in terms of the local therapy? Are we going to give the local therapy or not? Dr. Manish?
Yes, sir. We should use local therapy because the upper lobe tumor and it can be easily resectable for thoracic surgeon if allowed by the other parameters. So
So you
primary
will
lesion
opt
should be
for the surgery. Dr.
yes, sir.
Pulkit?
Sir, I would not opt for surgery in this patient. I will still treat this patient as metastatic because the site of oligometastatic is adrenal and axillary node. Had it been a single bone lesion, I would have still tried to go with the definitive RT to the primary lung lesion. Surgery in that case will still be a no. But in this case, I would still like to go with the treatment as a metastatic disease. That is my opinion.
Okay, but still, by definition, it is only 2 lesions and
Only
again less than 3 organs.
Understand, sir. But as per the site of the lesion, I don't want to add any a local therapy to
Okay.
even to the lung. Yeah.
Yes, point well taken, because we are talking about the very, it's a gray zone, and where we
Yes.
have very poor evidences for most of the things.
Yes.
There are few. Dr. Sachin, your take on this?
Yeah, exactly. The ideally in our routine practice, we generally continue the immunotherapy till progression in like these cases. But as we are discussing about the oligometastatic disease, the surgery is out of the question. I will not prefer the surgery, but only radiation therapy is an option which we can give at the primary site, at the axilla, and if radiation oncology is considered that adrenal is also amenable to radiation, or we can cover radiation therapy, then we can give radiation therapy to this site also. But what will be the survival advantage of all doing this? Still, I am not aware of that. But yeah, we can give radiation therapy to all these sites.
Also,
Yes.
sir, one more point I want to add, like if for lung, if we add radiation, usually we leave the opposite side mediastinal node. So if we are going, because we have to include axilla in, if we give radiation on a curative intent, then how much dose that axilla should receive and what are the potential complications for it? We are still not very sure on that also.
Yes, perfectly fine. It's a quite a gray area. That is what I'm saying. So I'll just surgery probably would be too extensive for this patient. Going for the like axillary dissection plus uh, addressing the lung and then adrenal. So there are certain trials which have actually evaluated in similar situation, though it is not a very great level of evidence. The maximum the level of evidence I'll say would be a uh, class 3. So there are few trials like the Gomez one, which has been done in the phase 2 RCT, and then stage 4 NSLC less than 3 sites. They have compared local radiation. So OS they have got is almost 41 months versus 17 months without local therapy, local consolidation therapy. Then there is some SINT-AS trial, that is again a phase 3 trial in EGFR mutant NSCLC. So this would be a one pivotal trial from where we can start thinking in the newer directions. So patient was EGFR mutant, and patient has received TKI plus upfront SABR to all sites wherever it was there, and OS was 25 months versus 17 months. And then the Comet trial, SABR Comet trial, it has included all the malignancies. Lung site was around 20%. And they have also shown the OS of 50 versus 28 months. So all the difference of opinion are accepted, but there are few evidences which suggest inclusion of radiation in such situation. Uh, Especially if there is a driver mutation, we can target these mutation, continue the treatment, and address with the radiation. Or as per the Comet trial, the OS is quite huge, so that can also be considered, though it needs a randomized data. But whatever data, especially these patients are not very common. We see rarely in such patients. I'll say around four, I guess 5 to 10% in our practice, where such excellent responses are there, and patient has only minimal disease. So in that situation, we can definitely consider EBRT. So that is a new, I'll say, new thought-provoking practice which we can consider. Even if we don't consider, still we are clinically right, or as per the evidence, we are right. But this, if the data improves, then definitely we can give that to patients. So as we have all the discussion, of all the three options, patient, next slide. So patient again took 7 cycles of pembrolizumab, and then subsequently, next slide, patient had myasthenia gravis related to immunotherapies. It was stopped and responded well to steroids. Next slide. Again, PET CT was showing near complete CR at axilla as well as lung. No adrenal uptakes. Next slide. Patient was subjected to EBRT to primary and the axilla. Offered adrenalectomy, oblique RT, patient was not keen. So patient completed the EBRT. Next slide. So rationale of the localized therapy in OMD in NSCLC. So there are few quick question. does LCT, localized therapy or localized conservative therapy, only benefit for those with a few metastases? Dr. Manish, is there any magic number?
No, sir, but only less than, only few can we deal with the
Yes,
local therapy.
by definition, it is less than 5. But I think
Yes.
we should also look into the location, as Dr. Pulkit was also suggesting. Adrenal mets, we always consider it will be a like overkill for the tumor. So we also need to consider patient's performance status, comorbidities, control comorbidities, then biology of the tumor, as we were discussing. So there are multiple things that we need to consider for the local therapy rather than going just with only one number. Dr. Pulkit, should we use surgery or radiation therapy?
Yes, sir, definitely. We can use also the one more important point is the location of the oligometastatic lesion. Suppose if it is confined to one single space, so that then the surgery becomes an easy option for those
Yes,
patients.
yes.
So I think depending on that, surgery both can be used, sir, depending on the
Oh,
location and the
both
number
or
of lesions.
combination of both?
Uh,
Both single,
Combinations,
like let's
uh,
say we have a one lesion which is not amenable to radiation, surgery, sorry. Then
yes, sir.
we can use the that only patient has two lesions. One lesion is amenable to surgery and other lesion is amenable to radiation at different places, not in the same organ.
Uh, I don't want to use that, sir. I don't want to use
Oh,
both the metastasis for two metastatic lesion, and might be unnecessary, might be complicate the case. But that is a MDT decision, sir. I think that also
yes.
includes how the oncosurgeon and radiation oncologists are confident about treating that patient, both the modalities in one patient. If they are very well convinced, then I think I would agree with them.
Okay, fair enough. Dr. Sachin, in response to, does it like in response to systemic therapy is a predictive marker for localized therapy?
Yeah, response to systemic therapy is a predictor marker because if patient is responding to systemic therapy, then it's a good disease and it's responding disease. And if it is not responding to systemic therapy, then it is a resistant disease. And
Yes,
even after
probably this is. Please go ahead.
and even after giving a localized therapy, it may appear somewhere else if it is not responding to systemic therapy. So it is
Yes,
a
probably this would be a biggest predictor. Responding disease only will go to for the if non-responding disease will have a like either a non-oligometastatic disease or polymetastatic disease. So probably this is the biggest predictive marker, but that is not probably that is not available most of the times upfront at the time of treatment. So we'll have to like wait for the response to come. How can we select the patients who are likely to benefit? That we have discussed, like multiple factors we need to consider. Is there any right time to introduce local therapy for maximum benefit? Your take on this last question?
So sorry to interrupt you. We are running short of time. Please conclude
Yes,
your thought.
this is the last question. We can conclude after this. For everyone, is there a right time to introduce local therapy for maximum benefit?
yeah, if
So
patient
I,
responded to systemic therapy very well, and now if we are planning for a maintenance therapy, and prior to that we can plan for a local therapy.
So you are
After
suggesting around 4 to 6 cycles of the systemic
yeah,
therapy,
yeah, yeah.
and I'm assuming that I'm response is there. Dr. Pulkit.
yes, sir, I agree with Dr. Sachin, sir, but also his patient is having a severe pain at the oligometastatic site, suppose at the bone or some other local symptoms are very high. Then there might be a possibility that we may introduce the local therapy prior to systemic therapy. Otherwise, in most of the cases, to see the response and to tone down the disease, systemic therapy has to be given first, followed by local therapy.
Yes, sir.
Dr. Manish.
I agree. Yes, sir. Definitely, this is the right.
Okay, basically, everybody is concurring that once the response comes, then we can introduce the local therapy. Response may come after 4 cycles or 6 cycles, whatever. In certain situation, immuno response comes in delayed situation. So basically, once the response is there, and we are very much sure that a patient has now oligometastatic or limited disease or minimal disease, then we can introduce the local therapy. So with this, I'll conclude this session, and I would like to thank again Dr. For Sachin for giving this opportunity and for wonderful discussion. Thank you all my panelists, including Dr. Manish and Dr. Pulkit and Dr. Sachin.
Thank you, sir. Thank you very much.
Thank you, Dr. Manoj, for
Thank you.
nice moderation of this fantastic topic, which is in a new era like oligometastatic disease. So again, thank you very much. Now, in the next session, I would like to invite Dr. Ajay Yadav. He will be talking on hepatocellular carcinoma. So over to Dr. Ajay.
Good evening, Dr. Sanchit, and good evening, all the listeners. So, from lung, now we move to liver, that is hepatocellular carcinoma. In next 20 minutes, we will discuss about what are the evidence for checkpoint inhibitor in management of unresectable hepatocellular carcinoma. Next slide. So these are the BCLC and ESMO guidelines for treating unresectable hepatocellular carcinoma. Patients who have advanced disease with portal vein invasion or extrahepatic site or with preserved liver function and performance status of 1 or 2, systemic treatment is the first line of first treatment of choice, and it includes atezo plus bevacizumab or durvalumab plus tremelimumab. If it is not feasible, the other options are sorafenib or lenvatinib or durvalumab. In second line, the options are regorafenib, cabozantinib, ramucirumab. Or in third line, we can use cabozantinib. And the similar recommendation is by ESMO. Atezo plus Bev is the first treatment of choice for metastatic hepatocellular carcinoma. Next. So these are the different clinical trials and different drugs that were approved for hepatocellular carcinoma, including SHARP trial for sorafenib, REFLECT for lenvatinib, CheckMate 459 for nivolumab, EMERALD for TES plus Durva plus bevacizumab, and IMBRAVE 150 for atezo plus bevacizumab. So in next couple of slides, we will discuss about IMBRAVE 150 that assess the efficacy and toxicity of this combination atezo plus bevacizumab in patients who have unresectable hepatocellular carcinoma. Next slide. So this is the trial design. Patients who are having locally advanced or metastatic unresectable hepatocellular carcinoma with at one or more measurable lesion having performance status of 0 or 1 with child-pugh class A and who have not received prior systemic therapy. Patients were randomized to atezo 1200 milligram every 3 weekly plus bevacizumab 15 mg per kg every 3 weeks versus sorafenib 400 milligram BD. It was 2:1 randomization. This was an open label study where no crossover was allowed. Patients were stratified according to the region, performance status, and baseline AFP level. The primary endpoint was overall survival and PFS. Secondary endpoints were response rate and quality of life. Next. So these are the baseline characteristics. We can see that both the arms were well balanced in terms of median age, sex, region, performance status, BCLC stage. And in both the arms, around 1/3 of patients have received prior TACE therapy and 10% patients have received prior radiotherapy for the localized disease. Next slide. So this is the subgroup analysis, high risk versus non-high risk. In IMBRAVE trial, 21% patients were having high risk who have tumor of more than involving more than 50% of liver area with bile duct invasion and hepatic vein thrombosis. And it was 15% in the sorafenib arm. Next. So these are the results. Overall survival, we can see that the curves were separating right from the beginning and this separation was maintained.
With Atizo plus Bev, the median overall survival was 19.2 months versus 13.4 months in sorafenib. This blue line is for Atizo plus Bev, and this red one is for sorafenib. The hazard ratio in this for the oral survival was 0.66. Next slide. If you look at the PFS, the median PFS was significantly better with Atizo plus Bev. It was 6.9 months versus 4.3 months with hazard ratio of 0.65. Next slide. So, Atizo plus Bev results showed that there was high response rate and CR rate. If you look at CR rate, it was around 8% in Atizo plus Bev. The PR was in 22% patients and stable disease was in 44% patients. While in sorafenib arm, the CR was less than 1 and PR was 11% and stable disease was in 43% patients. Next. This is the overall survival according to subgroup, and here we can see that all the subgroup were benefited. Either they were from according to the region having or performance status, BCLC stage, or etiology of disease. All the subgroups were benefited with this combination of Atizo plus Bev. Next. So, post hoc analysis of outcome according to etiology has shown that the disease etiology and outcome after Atizo plus Bev in hepatocellular carcinoma has not shown any difference in the survival outcome, and there was no significant difference in proportion of patients who had the response across the etiologies. Next. This is the post hoc analysis, and according to disease etiologies should not be factored into consideration when using Atizo plus Bev in patients who have unresectable hepatocellular carcinoma. Next slide, please. So, IMBRAVE 150 has shown efficacy of Atizo plus Bev irrespective of the etiologies. In patients who have non-viral etiologies, the median PFS was 7.1 versus 5.6 months, and the response rate was 27 versus 9%. In patients who have hepatitis B positivity, the median PFS was 6.7 months versus 2.8 months, and the response rate was 32 versus 8. In patients who have hepatitis C virus positivity, the median PFS was 8.8 versus 5.8 months, and the response rate was 30 versus 21%. Next slide. If you look at the checkpoint-induced toxicity, there was no difference in the toxicities in comparison to other trials where the checkpoint inhibitors were used, and these toxicities were manageable. Next slide, please. So there was no clear pattern across the endpoints, and sub-analysis has shown that hypothesis generating only and not conclusive. So there was no difference in the toxicity according to the etiology of the disease. Next slide. The next thing is about quality of life. If you look at the result, we can see that there was significant improvement in quality of life with Atizo plus Bev with a hazard ratio of 0.63. The patients, the major toxicities, grade 3 and 4 toxicities in Atizo plus Bev arm were hypertension in 10% cases, transaminitis in 4% cases, proteinuria in 3% cases. While in sorafenib arm, hypertension, hand and foot syndrome, diarrhea, and decreased appetite were the common toxicities. Next. So the concept for treatment goal in unresectable hepatocellular carcinoma is that we should consider these goals in management of these patients. We want to improve the survival. We want good direct anti-tumor effect, that is PFS and response rate. We want manageable side effects. We want to preserve the quality of life and preservation of liver functions for subsequent therapy. Next slide. And the priorities requirement for first line systemic therapy is that we should aim the wide benefit and the therapy should be less toxic. Next slide. Here we can see that Atizo plus Bev in comparison to sorafenib have shown improvement in overall survival, improvement in PFS, and with maintaining the quality of life for these patients. Next slide, please. Next. Even in patients with stable disease, they have reasonable overall survival benefit, and the rate of toxicities were manageable in these patients. Next slide. Atizo plus Bev demonstrated greater depth of response. In these curves, we can see that tumor shrinkage was more with Atizo plus Bev in comparison to sorafenib. The tumor shrinkage was less in sorafenib arm. Next slide. So the median follow-up duration was 20.2 months in tumor shrinkage population and 7.6 months in non-tumor shrinkage population. So the patients who have more tumor shrinkage, the duration was maintained in these patients. Next slide. And this is the duration of response. It was more with Atizo plus Bev in comparison to sorafenib with a hazard ratio of 0.38. Next slide. So three factors of tumor response for long-term survival are high response rate, deep response, and long response. And we have seen that Atizo plus Bev satisfies all these three factors in this study. Next. So if we look at subgroup analysis, we will find that patients who have tumor thrombosis, they were also benefited with Atizo plus Bev in comparison to sorafenib. The median overall survival was 21 versus 15.4 months, and median PFS was 7.1 versus 4.7. And CR rate was 8% here with Atizo plus Bev in patients who were not having tumor thrombosis. While in patients who were having thrombosis, if you look at the comparisons, the median overall survival was 7.6 versus 5.5 months. In patients who received Atizo plus Bev, the median PFS was 5.4 versus 2.8, and the response rate was 23 versus 13. And the toxicities were similar in both the arms. Next slide. So, despite the treatment duration for the patients with Atizo plus Bev was around 3 times longer than sorafenib arm, and similar incident rate of toxicities between the two arms were observed. Next slide. So in patients who are having esophageal varices with the bevacizumab, there are higher chances of bleeding. But if you look at the comparison, I am Brave 150, the OS, PFS, and response rate were better in with Atijo plus Bev in patients who have varices. Here you can see the efficacy of Atijo plus Bev in patients who have esophageal varices. The median oral survival was 17.7 months versus 8.6 months with hazard ratio of 0.55. Median PFS 7 months versus 4 months and response rate 30 versus 17. And it was comparable with patients who were not having esophageal varices. Next slide. So IMBRAVE 150, the majority of bleeding events with Atijo plus Bev were unrelated to varices, and the common bleeding sites were epistaxis, and majority of bleeding events with Atijo and Bev were grade 1 and 2. Next slide. So all the patients who are going to receive Atijo plus Bev endoscopy, upper GI endoscopy should be done in these patients, and esophageal varices should be identified. And the optimal time to wait between band ligation and initiation of Atijo plus Bev to minimize the risk of bleeding from banding is unknown, but usually 2 weeks is likely reasonable time for the patients after post banding of these esophageal varices. Next slide. So the treatment goal for these patients who are having BCLC stage B is tumor shrinkage, necrosis, and cure by combination of systemic therapy and local therapy. Patients who are having BCLC-C, the goal is to prolong the survival by multiple line of treatment while maintaining the liver reserve. And now we will see what was the results of Atijo plus Bev for these targets. Next slide. Next slide, please. So time to determination of quality of life. Quality of life was better in patients who receive Atijo plus Bev in comparison to sorafenib. And the physical functioning was better, and it was better with combination of Atijo plus Bev. Next slide. Change in ALBI score with Atijo plus Bev, up to 30 cycles, patients who were treated with Atijo plus Bev, they still maintained ALBI grade and continued to receive the treatment. Next slide. What was the effect of this combination of subsequent therapy? So more than 70% of patients were eligible to receive second line treatment who received this combination, and the liver functions were preserved for these patients, and first line should be, so this benefit showed that first line treatment should be Atijo plus Bev so that liver functions and the quality of life can be maintained and further line of treatment can be given to these patients. Next slide. This slide shows real world data, 5-year overall survival from different sites, and total 54 patients. 90% were male and median age was 65 years. At the median follow-up of 79 months, the median overall survival with the checkpoint inhibitor plus bevacizumab was 19.6 months, and 16 patients, that is around 30% patients, had overall survival of more than 36 months in this study. Next. So with this, we can conclude that IMBRAVE 150 suggests that Atijo plus Bev demonstrated consistent clinical meaningful benefit in comparison to sorafenib, with median overall survival of 19.2 months versus 13.4 months, median PFS 6.9 versus 4.3 months, response rate 30 versus 8%, with a good safety and tolerability profile. It remains consistent with the non-safety profile of each individual drug and underlying disease. And Atizo plus Bev provides one of the longest overall survival seen in frontline phase 3 study in advanced hepatocellular carcinoma with high-risk baseline characteristics, confirming this combination as the standard of care for patients of unresectable HCC who have not received any prior treatment. And effectiveness and tolerability profile of Atizo plus Bev remain consistent with the clinical trial data. With this, I thank you all of you. Thank you, Rose, and thank you, Dr. Sanchit Jain, for this opportunity.
Thank you, Dr. Ajay, for a very nice presentation on the role of Atizo plus Bev in hepatocellular carcinoma, which is effective across the viral or non-viral etiology. And I have also few patients who are running on Atizo and Bev, and they are from more than 2 years doing very well. So this is all today's webinar. So at the end, I would like to thank to our all esteemed speakers for sharing their valuable insights and expertise with us today. And your presentations were very informative, engaging, and thought-provoking. I also appreciate the active participation, my all panelists, and thank you very much for making this 2 days webinar successful. Thank you very much. And I also want to thank my organizing committee, Tarunji, Nishanji, and Sakshiji, for their active participation and making everything in a flow and very smooth managing this webinar. Thank you very much.
Thank you, sir. Thank you, everyone, for joining. And thanks to Nishant and Sakshi, my colleagues. Thank you, everyone. Good night, everyone.
Thank you.